Well, hello, and thank you for joining me for episode 5 of the Healthy Skeptic MD podcast. I am your host, Dr. Michael Hochman. I hope your month is off to a good start. It's been a good October so far for you, wherever you are. So today I'm going to talk about a topic that is relevant to a lot of people, and that is cancer screening. My guest is someone who I have admired from afar from a long time. Never met him before today. His name is Dr. Gil Welch. He's a public health researcher and doctor at the Brigham and Women's Hospital in Boston. And the reason that I've always admired Dr. Welch is he's someone who's not been afraid to express ideas and publish data that goes against the standard medical dogma. So what you're going to hear from Dr. Welch today is some ideas about why cancer screening may not always make sense, why it may not always be right for everybody in every situation, and some of the harms of cancer screening. I think it's very important information to take in. It certainly influenced me and resonated with me, but it is controversial. So as always, I would just recommend take it in, consider it, and maybe think about it the next time you are up for that mammogram or prostate cancer or whatever the screening test may be. If you do like what you hear today, please do search for us and subscribe wherever it is that you listen to podcasts, whether that be Spotify or Apple Podcasts or wherever that is. Or you can also find us on our YouTube channel. Healthy Skeptic MD is what you want to look for. As a point of clarification, we are not the Healthy Skeptic, which I'm sure is also a great podcast. But if what you're interested in is what you're hearing today, it is the Healthy Skeptic MD that you are looking for. Okay, before we get into our interview with Dr. Welch, I just want to cover 2 news items of the week that you might want to be aware of. The first has to do with the topic of intermittent fasting for weight loss. Now, on a normal week, this would probably be a key headline in major newspapers, but we, of course, are in the middle of a pandemic and a presidential election that some of you may have heard of. So it didn't quite get the attention it might otherwise have. So this is the largest, most rigorous study yet, certainly that I'm aware of intermittent fasting for weight loss. They took 116 overweight people who wanted to lose weight, and they randomly assigned them, and half of them got a standard low-calorie diet, 3 meals a week. The other half did intermittent fasting, in which they did not eat from 8 p.m. in the evening, overnight, and the next morning until 12 p.m. the next day. So in total, it was 16 hours of fasting, followed by 8 hours in which they ate. Now, some previous studies have had favorable findings with respect to intermittent fasting. This one did not. There was no greater weight loss in the intermittent fasting group. But like I said, this is the best, most rigorous study on the topic to date. So it's certainly the one that I would trust. Now, we'll certainly come back to the topic of weight loss and different approaches because this is such an important topic, and we'll cover it again in the Healthy Skeptic MD. But I'll just say in a nutshell, what the data tells us is that no particular diet, low carb, high carb, low fat, high fat, is proven to be any better than any other, at least not consistently. What the data seem to show is that whatever diet it is that you can comply with, that you can eat and sustain and obviously have fewer calories, that's probably the best diet for you. But again, we'll come back to that topic. The second news item I wanted to mention today is actually not really a new research study. It's just a great New York Times article that I came across. It's titled, "The Pandemic Highlights Deep-Rooted Problems in the Indian Health Service." It focuses on the Navajo Nation and describes how the rate of COVID infections has been about 3 times the national average, and death rates have been about as high in the Navajo Nation as they have been anywhere in the nation. It's a topic really of personal importance to me because I spent about a year there during my medical training. It's a wonderful culture, and the article highlights this, but it also highlights some of the big challenges that they face on the reservation, where many of the houses do not have running water or electricity. So it's a great article to read and learn about the Navajo reservation and the challenges they've encountered, and it also gives you a real good appreciation for how lucky we are to have running water and electricity. So that's it for the news summary for the week, and let's go on to our interview with Dr. Welch. Okay, well, for today's interview, we're very lucky to have our guest from Vermont, Dr. Gilbert Welch. I've been a big fan of Dr. Welch since I was doing my medical training, and has really, in a lot of ways, been an inspiration from a lot of my philosophy in healthcare and medicine. He is a senior researcher at the Brigham and Women's Hospital in Boston, although he does live in Vermont. He's a public health researcher. He's been one of the leading voices in the world, really, questioning our assumptions about the value of medical care. And I should say he's not someone who doesn't believe in Western medicine or medical care, but has just, highlighted the nuance that's involved. So welcome to the Healthy Skeptic MD, Dr. Welch.
It's great to be here. Thanks for having me.
So let me begin with a simple one. When did you first become concerned that something wasn't right in our healthcare system?
Well, you say it's a simple question, but actually, of course, there are multiple forces at work. And I should credit my parents. My father was a political scientist at the University of Colorado. My mother was a hospital trustee in Boulder, Colorado. So the politics of healthcare was something, politics and sort of economics of healthcare is something I grew up with. Then as a resident in Salt Lake, I began to experience the possibilities that we would admit someone who was perfectly well for an evaluation of some abnormality, typically on their chest x-ray, and then something bad would happen in the hospital. You started with a well person and you realized something bad happened in the process of trying to evaluate, trying to anticipate what their future was going to be like. You have complications from procedures. That's part of the business.
Do you think we provide too much medical care in the U.S.?
The simple answer is yes. I want to be clear, though, to your audience that medical care can do a lot of good. And I really genuinely believe that. And it's particularly in people who are acutely ill or injured and people who are suffering. And if you have a problem, please come see your doctor. Do we do too much? Sure. And I think it happens at sort of two ends of the spectrum. And one is towards the end of life. That's not been a big part of my career, but it's definitely a big issue that we've made dying hard in this country. And that's a very important issue. I don't feel like I have any special expertise on it, but we definitely provide too much medical care at the end of life and not enough compassionate care. I've been concerned about the other spectrum, what we do for the well, people who have no complaints, who we sort of invite in to see if we can find something wrong with them. That is a very tricky calculus, and that's where I think we're doing too much. What I would call anticipatory medicine, where we're trying to guess what might go wrong in the future.
Your points really resonate with me. The only thing I might add is that I also feel that although we provide too much care in some circumstances, we don't provide appropriate care in others. For example, some of the uninsured and vulnerable populations don't get those basic services like diabetes care and so forth.
Absolutely. Absolutely. We have barriers to care for people who really would benefit from it. We have the highest medical care expenditures of any country on the planet. And yet, our life expectancy is relatively low for a developed country. And why is that the case? Well, it's because medical care really isn't that important a determinant of a population's health. It's very, very important for people who are acutely ill and injured, but it isn't what's going to change the overall health of a population. That's more basic things. That's more basic things like income, housing, education. Those social determinants of health are really what is key to having a healthy society.
And maybe if we didn't spend so much unnecessarily in medical care, we would actually have more resources to support those root causes of health. Okay, well, let's move on to screening because that's what you're really nationally, internationally known for. It's intuitive that preventive care is a good thing, that screening for cancers, for example, breast cancer, if you can catch it early, you can improve outcomes. The first time it occurred to me that there also might be some downsides of this was when I was doing my medical training. I had two cases back to back. The first was a patient who I had seen in clinic with my preceptor who had some lung disease, and we ordered a CAT scan really just to check what was going on in the lungs. There wasn't a clear reason, a new symptom. There was also maybe we would see a lung cancer, we could catch it early. So we did see a nodule, and the patient ended up getting a biopsy, and that actually, the needle caused the lung to collapse, and the patient ended up in the ICU. Unfortunately, she survived, but she didn't come out of it in the same state of health that she was. And then right after that, I had another patient who I was also seeing in the ambulatory setting, and I was just chit-chatting with him, and he had been diagnosed with prostate cancer several years before. And I said, how was it diagnosed? And he said through a screening PSA test, the common blood test for screening for prostate cancer. And he said, that was a huge mistake. And I said, why? He said, I was doing perfectly fine. And then I got screened and I had surgery and I got radiation. And since then I've been incontinent, sexual function has gone. And he got further and further debilitated, and he was actually in a wheelchair, and he pinpointed it all to that diagnosis of prostate cancer. So that was the first time that it occurred to me that it might be more nuanced than that. So how is it that a preventive service like cancer screening could be a bad thing?
Well, I think the first thing people need to understand is that the word cancer implies this huge heterogeneity of growths. And there are a lot of abnormal growths that meet the pathologic definition of cancer, but they're not destined to cause death, and they're not destined to even cause symptoms. Consider it like a silent reservoir of disease. It's lurking under the surface. And whenever we look hard for cancer, we begin to unearth some of these things that meet the clinical, meet the pathologic definition of cancer, but are never destined to cause problems in that patient. That's the problem of overdiagnosis. And let me just share with you an analogy that I think dates back to the 50s from a cancer surgeon about the barnyard pen of cancers. And there are three animals in the barnyard. They're the birds, the rabbits, and the turtles. And the goal of early detection is to catch these things early, is to fence them in. And you can immediately imagine the problem with the bird. You cannot fence in the bird. The bird's already flown away, and these represent the fastest growing cancers, the most aggressive cancers, the cancers that have already spread by the time they're detectable. Clinically, you may be familiar with this, breast cancer in very young women. It happens, women in their 20s, develop a very aggressive cancer, and it's terrible. It's a terrible disease, no question. Those are the birds. Screening can't help with the birds because they're already spread. Then there are the rabbits. The rabbits are hopping around, and you can catch them if you build enough fences. These are the more slowly progressive cancers, the cancers that can be detected early. And this is the place where screening may help if earlier treatment's really better than later treatment. But then there are the turtles. And these are things that meet the pathologic definition of cancer, but they're not going anywhere. They're not going anywhere. You don't need to catch them early. You don't even want to catch them. Unfortunately, screening's really good at detecting turtles. Unfortunately, we doctors aren't good at sort of discerning which is which, so we tend to treat everybody, thereby causing the major harm of cancer screening for an individual, that is, to be treated for a cancer that was never going to bother you. And, of course, our treatments can hurt you.
Now, I always get the question from patients, but what if I am one of those people who does have one of those rabbits that we can catch and actually make a difference?
I think people have to accept the sort of realities of screening. And if I had to write a bumper sticker, and really make it as simple as I know how, I would say a few are helped, a few are hurt, and most go through the process for nothing. I mean, that's the reality of the thing, and yet many people will experience some false alarms, be made anxious by the process, will have to pay stuff out of pocket. I'm not saying there's one right answer for any one person. I think people can look at the data and come to different decisions, but there's no question that no screening test in the general population has ever been demonstrated to change someone's life expectancy. change their risk of death from all causes.
Yeah, so this is an important point that although some of these screens like breast and prostate cancer screening may lower your risk of dying of those cancers, they actually haven't been proven to extend your life.
I mean, what screening may do is lower your risk of dying of the target cancer, but even that is in dispute, particularly in breast cancer right now. But I'm sure we'll get to breast cancer in a second.
Last year, you published a very important study in the New England Journal looking at what you called epidemiologic signatures of cancer. So, for example, you looked at lymphomas, leukemias, lung cancer, GI cancer, cervical cancer, breast cancer, and a number of others. And the study raised a number of important questions about what the impact of all this in some cases screening, in other cases just sort of looking more closely was having on rates of death for these cancers and overall death rates and diagnosis rates, I should say. So I guess let me begin at the highest level. Are we making progress based on your evidence in our war against cancer? And if so, which cancers are we making the most progress on?
The answer is yes. We are making progress in cancer, and by far the greatest progress is in lung cancer. And that's really not about medical care. That's really about public health efforts to get people to smoke less. And we're really beginning to reap the benefits of that now. That's why overall cancer mortality is going down. Almost all of that relates to lung cancer mortality, which is by far and away the most common cause of cancer death in this country. And it is slowly going away, and that's good. So no one should be confused about that. That's a very good piece of news. Our treatments are getting better, particularly in breast cancer. The understanding that this is frequently, overwhelmingly frequently, a hormonal responsive tumor, that was really important to learn. And our drugs that can deal with the hormonal response are real breakthrough drugs. Same thing in prostate cancer. A fair amount of that is hormonally responsive. Those were really good things to learn. And I think those things are things we should be very proud of. Then in some of the rarer cancers that don't kill that many people but can be very, very hard on selected individuals, we've made real progress, and those are the hematologic malignancies, the so-called blood-borne cancers, things like chronic myelogenous leukemia and Hodgkin's disease. Real treatment improvements there. So yes, we are making progress in cancer.
Okay, well, that's good to hear. And it sounds like a lot of that owes to scientific advances in treatments, and certainly in the case of lung cancer, reductions in smoking. But your research also does suggest some concerning implications, especially for thyroid, skin, and kidney cancer. So the data suggests that the rates are rising, but surprisingly, mortality has not improved despite all the advances. So you suggest this may be because we're finding more of those turtles, those slow-growing cancers that wouldn't otherwise cause any problems. So how, again, explain how this can be happening.
To me, this is the classic picture of overdiagnosis, where you have rising rates of incidence with no change in mortality. And you understand why those incidence rates are rising, because there's more testing going on. And probably the most profound example in the world is in South Korea in the early 2000s. General practitioners started ultrasound screening for thyroid cancer, and 15 years later, the country had experienced a 15-fold increase in thyroid cancer incidence, and this was, unheard of. Thyroid cancer became the most common cancer in South Korea, more common than lung, more common than breast, more common than colon. And those thyroids came out, and that's not good for patients. To me, this was like a powerful wake-up call that, yeah, you can look too hard for cancer and you end up treating way too many patients.
Right. So not every nodule is is trouble.
Absolutely not. If every nodule was trouble, we'd all be dying of thyroid cancer. I mean, in adults, nodules is just a very common finding.
Okay, well, let's move on to breast and prostate cancer. The situation here is more nuanced. What your data seem to suggest is that we're finding more of these cancers, but on the positive side, outcomes are actually improving. So is it possible that the improvement is from screening?
Not in and of itself. It means something good is happening. Everyone should agree. When mortality is going down for a cancer, something good is happening. And something is good happening in breast cancer. Mortality has fallen almost 40% since 1990. That is great news. But it's largely about treatment and not screening. And you might say, well, why do you say that? Well, I have a number of articles looking at it in a bunch of different ways, but I think the simplest explanation for people to understand is that the rate of breast cancer death among women who are age 40 and older, the group we usually screen, has gone down about 40%. But the rate of death in people under age 40 has also gone down 40%, actually gone down a little bit more, and that's the group we don't screen. Now, I don't know of any data that's simpler than that. We're seeing the declines both in a screened and an unscreened population. That means it's largely about treatment. Plus, we have a lot of randomized trial data about the advantages of treatment.
There have been 9 randomized trials of screening breast cancer. There was a review by the Cochrane Association on that. And the conclusion of it was that in those rigorous randomized trials, breast cancer screening mammography does not actually cause people to live longer. There was a modest reduction in breast cancer specific mortality, but if our real goal is to live longer, according to those studies, that was not happening.
And I think importantly, if I can interject, the trials are all pre the change in treatment. It's possible mammography was more important in the 70s than it is today. The better we get at treatment, the less important it is to find disease early.
Well, another one I want to spend a little time on, because we do a lot of it, is colon cancer screening. So this is another nuanced situation where we have seen reduced rates of colon cancer, which is a good thing, as well as improved outcomes. Again, there could be many explanations, from treatment to dietary changes. And then, of course, that screening could be preventing some of these cancers, because, of course, with colonoscopy, we see these precursors and they potentially can get removed. So what's going on with colon cancer?
Well, this one's personal. My father died of metastatic colon cancer in 1978. He was age 60. So in many ways, this is the cancer I've been thinking about the most. It is interesting that the year my father died, 1978, was absolutely the peak incidence of metastatic colon cancer. And it's been dropping every year since. Now, this is long before we started routinely screening for colon cancer. What's going on in colon cancer is really interesting. I think the disease is slowly going away, whether that's something about diet, whether that's something about the bacterial flora. I think that's a question to ask. But I think screening helps a little bit. We've made it extremely resource intensive by choosing colonoscopy as or is sort of the prime way we do it, which is literally taking people to what's essentially an operating room. Everybody, as they get older, a number of times. That's a very and bad things can happen during colonoscopy. Not often. It's not common. I don't want to mislead anybody.
Yeah, well, I certainly think all these studies are very humbling for primary care doctors like myself. I think we do a lot of good things, but the screening, it may be not as high value as many of us think it is. I do want to give some credit where credit is due, and that's just cervical cancer screening. I've personally been compelled by the data that this is probably one that makes sense in most women. And this is something that also you seem to support based on the data in your study. Did I capture your belief on that correctly?
Let me say, even there, and again, I want to credit physicians now. We're slowing down, and that's good. First, this is a very rare cancer. There's another cancer that is going away. It's like 1/5 of what it would have been in 1950. The only other cancer that has fallen so dramatically, you want to guess what the other one is?
Lung?
No, stomach. When was the last time you saw a case of stomach cancer?
Stomach. Yeah.
But that was one of the most common. And everybody wants to attribute the change in cervical cancer incidence, new cases, that decline to screening. Some of it may be screening, but I think something else may be at work too. And I think the stomach cancer example is important because no one's screening for stomach cancer. And yet it's gone down the same amount. So it's important not to credit medical care for everything. And I know as doctors we'd like to, but remember that things do change in environments and the way people live do change.
It certainly is humbling. I just want to close out with one final point on cervical cancer, which is that there actually are harms of that as well. I've seen women who have had colposcopies, which are the follow-up procedures for abnormal pap smears, and they get some of the cervix excised and they have fertility issues. So there absolutely are some downsides, even though the data do on the whole suggest that there is some benefits as well. So there is that trade-off and mix there too.
It used to be every year till, my mother was continuing to get pap smears into her 80s. Like, how crazy is that? And I think now the medical profession is more aware of the downsides of screening. And so appropriately, we're not doing it as frequently. We're stopping early. I think that's really important. It's really important to get balance here.
Okay, Dr. Welch. So there's few people who know more about the epidemiology of cancer screening than you. For you and your family, which cancers do you plan to get screened for?
Well, the obvious question to start with is colon cancer, and how did I handle that? And I discussed that in my book, but I'll just review it here. I have two older brothers who approached me. They're not physicians. They approached me, our dad died. What would you suggest? And I said, I would get a colonoscopy at 50 and just see what your colon looks like, whether you're a polyp former and so forth. They both did it. And of course, I was sort of, oh gosh, it's my brothers. I got to just tell them to be part of the system and see what happens. So I turned 50. What am I going to do? And I thought, well, geez, I told my brothers to do it. I should do it. I've been ordering it on patients. I'll get a colonoscopy. So I did have a colonoscopy, and I had a totally great time. I know that sounds really weird to your audience, but it was a wonderful experience. I didn't think I'd do it again, and I haven't. It was 15 years ago. I don't think it has that powerful. I really did it as much just to have a patient experience myself. I thought it was important. It was important more for me to have that patient experience. I don't think it changed my risk of cancer at all. And I may die of colon cancer. I may die of prostate cancer. I may die of dementia, but I will die. I'm not going to spend a whole lot of time trying to worry about what it is. I'm going to try to pursue. Oh, and PSA. What do you think? Have I had a PSA? What would you guess?
I would guess not, and I'm not planning to get it myself either. I think the harms outweigh the benefits on that one.
To me, it's an easy decision. Yes, I might nominally change my risk of prostate cancer death by lowering a little bit, but I do that at the cost of a much greater risk of impotence and incontinence now. And this difference between, you have to remember, the harms of screening tend to be in the near term. They're now. If I have an abnormal, I got to get a biopsy, and then maybe I get infected after my biopsy, and maybe they find a cancer, and then maybe they get me worried, and I get operated on, and then I'm incontinent. All those things are near term. The benefits are something in the future, if the benefit exists. And to me, it's an easy. call. And I'm not saying everybody should make my decision. I just want to give people permission to say, no, I don't want this stuff. I definitely want healthcare when I'm sick, when I'm suffering. I want a physician who will help me towards the end of life to be as comfortable as possible. Absolutely. That's not, but I don't want to get involved with the system unnecessarily because I know it's a really close call and bad things can happen.
Well, in my case, I would agree with your plans as well. I'm not planning to get prostate cancer when I turn 50. In terms of colon cancer, the only difference I might have with you is I might actually go with the stool card because I have seen people who have had complications from colonoscopy, a perforated colon. There was a patient I saw who had that once.
Well, I agree with you. I think we're going to see that the fecal occult blood is every bit as good as colonoscopy, and it's much simpler.
As much fun as you made the colonoscopy sound, I'm not sure everyone would have that same experience. Well, I think the other really important point you made in there is we certainly don't want to force these tests on anybody. We want to make sure that people feel comfortable saying no. And that's my approach with mammography, also with my family members, my mother, for example. It's not the issue I'm going to push. I want her to get that flu shot. I want to make sure her blood pressure is under control. I want to make sure she gets good pain management, but I'm not going to pick the battle if mammography is not what she wants to do, just because the value is so low.
My question for you as a physician is, do you feel pressured? To me, this is the dark side. Is the performance measurement issue makes you pressured to do mammography?
I am measured on my rate of mammography, and that's less of my concern. The couple dollars I would get from performance metrics is just not worth it enough to influence my practice. But for me, it's more the concern, what if I don't recommend a mammography and God forbid someone dies of breast cancer? Even if that mammography wouldn't have changed the outcome, will I be legally held accountable or morally held accountable? So my approach is I always offer anything that's recommended by the United States Preventive Services Task Force, but I don't push it. I say I make sure that people know it's a choice, it's an option, there's pros and cons. It is recommended by the guidelines, but that does not mean you have to do it if it doesn't work in your particular situation.
But you can see why a lot of doctors do push it, even if they don't really believe in it, right? That they feel they need to push it. You can understand why that happens.
Absolutely. And there are other doctors who work in systems where those pressures that you mentioned, financial incentives for getting their screening rates up, are actually very meaningful and influential.
And I think patients ought to know that. See, I think that's one thing I would tell your listeners is to ask their physician whether they're under any pressure to recommend this or have you do this.
Yeah, I think the other underappreciated factor that influences is time. It's much simpler just to say, get the mammogram and not to have a nuanced discussion about it. And we have 8 minutes in many cases. And I have many good colleagues who really do understand the pros and cons, but they just don't want to use 3 or 4 minutes of that 8 minutes they have with the patient to have this discussion. But in my case, in my view, I do think it is important.
Absolutely. No, I hear you totally. And patients should realize the pressures their docs are under.
Yep. And so I even recommend in some cases that they do a little homework. They read about mammography or screening from a reliable source, and they come in prepared to have that discussion with me so we can make it as streamlined as possible.
It is interesting that we're much more comfortable giving men the choice about whether to have a PSA than women the choice to have a mammogram. That's interesting, isn't it?
I think it is interesting. Part of it is the guidelines, though. The mammography guidelines are stronger in favor of screening, whereas the PSA does provide that wiggle room. But you're right. If you looked at it from a purely data standpoint, I think the situations are very similar.
And well, honestly, I think prostate cancer screening has more of an effect on prostate cancer mortality than mammography does on breast cancer mortality.
Yeah, certainly there's an inconsistency there. Well, the last question you asked me gets at the last question that I wanted to ask you, which is about the explanation for why our system is the way it is. Why is it that we provide more medical care than maybe is necessary, both screening tests and otherwise. In your view, what are the pressures that lead to this situation?
Well, I think there's a complex web of forces working here. The first is true belief, right? I mean, it's so simple. How could it be wrong? I mean, it just seems like early detection is always in your advantage. And it's only when you understand that there's this whole population of things that can be found if you try to look early that you begin to realize it's much more of a mixed bag. But true belief is part of it. It must be good to try to look for diseases early. The other extreme is money. I mean, this is a good business. Screening is a great way to find new patients for a system that is volume driven, and our healthcare system is very much volume driven. There's a lot of other issues, of course. You mentioned lawyers. I think physicians are always concerned about lawyers, and they're always concerned that they want to have done everything, that the act of omission is somehow worse than the act of commission. And so we tend to order tests. And then the last one I alluded to a little bit earlier is the performance measure, this desire to measure doctors on how well they're doing. Well, it turns out it's really hard to decide how well we're doing on sick patients. That's a really tricky thing to decide how good we're doing with sick patients, even though that's what really matters. So they defaulted to really brain dead measures of, what proportion of your female population are you giving a mammogram to? I don't know if that really measures quality. I don't think it does. But it became a very powerful tool, and I think it's has very unfortunate side effects that make us a doc say, I don't have time for this. I'm just doing this stuff. It's all, I just got to get it done and move on to the next patient.
Well, I downplayed a minute ago your point about whether the influence on my decision-making that performance metrics have, but I will say on our system level, it has a big influence, and we've gotten some quality improvement bonuses, and our health system has invested that in things like getting our colon cancer screening rates to the highest possible level, when I think those dollars could be used in so many other more important ways. So even if it's not at the individual doctor level, it just leads to a misappropriation of resources.
I do think doctors are much more sensitive to this problem now than they would have been 10 years ago. And that's good. I think more people in the profession understand the downsides of early detection and that it has to be managed, and looking harder isn't always in your interest, and being screened every week isn't in people's, that this is something that you really need to be careful with.
Well, I think that's a great point to end on. And I really think that some of the credit, at least about the change in philosophy over the last 10 years, has stemmed from the work that you've done that's highlighted the harms of overtreatment. I know this was a nuanced and complex conversation. I really appreciate your joining us. I would just like to say to the listeners that there were many important points that came out of this today, but I think if there's one overarching take-home message, it's don't be afraid to ask your doctor why a certain service is being done. Do it in a respectful, thoughtful way, but there's a lot of things going on in the background and pressures and motivations that can lead the train along, and you end up getting services that you don't need or may even cause harm.
I agree. And the one other thing I'd like people to know is don't think you can test yourself to health. You really need to listen to what your grandmother would have told you. Eat your fruits and vegetables, go play outside, and by all means, don't start smoking. I mean, these very basic, I know they're not sexy, they're not high tech, but you and I both know these are really important for people. And it is important to pay attention to your health. It is important to get enough sleep. It is important to eat well, and is important to move regularly. Those are really basic things. Don't think you can get out of that by testing yourself.
Well, you encapsulated in a soundbite there what the purpose of this Healthy Skeptic MD podcast is to focus on all these issues that really drive health more than some of the medical services that we do, and figuring out which medical services are the ones you really do need. Well, I so appreciate your taking the time, Dr. Welch, to call us from the East Coast today, and look forward to continuing to follow your work.